Welcome to the Irish Practice Nurses Association online education series for general practice nurses. My name is Teresa Lowry-Lenin. I'm a member of the Carlow branch of the IPNA, and today I'm going to discuss meningitis, looking at the etiology, symptoms, diagnosis, treatment, and public health responses. Meningitis is an acute inflammation of the meninges, the protective membrane that surrounds the brain and spinal cord. It is caused by bacterial, viral, and less often parasitic and fungal infections. The bacterial form of meningitis is the most severe. Viral meningitis, while it can make people feel very unwell, is rarely life-threatening, usually resolves on its own, and seldom causes any long-term complications. Bacterial meningitis, however, is a serious illness, a medical emergency, and a public health concern. Bacterial meningitis is an infectious disease associated with substantial mortality and a risk of permanent disability in survivors. Mortality remains as high as 30% in pneumococcal meningitis, 5 to 10% in meningococcal meningitis, and up to 50% when untreated. Outcomes are improved by prompt recognition of symptoms and treatment with dexamethasone and intravenous antibiotics, which is intravenous benzylpenicillin, which should be administered as soon as possible and preferably within the first hour. Several types of bacteria can cause bacterial meningitis, including Streptococcus pneumonia, Haemophilus influenzae, Neisseria meningitidis, Listeria monocytogenes, and Group B Streptococcus. The average incubation period is 4 days, but it can range between 2 and 10 days. Early symptoms of meningitis include nausea and vomiting, fever, headache and a stiff neck, muscle pain, light sensitivity, confusion, cold hands or feet and mottled skin, and in some cases a rash that does not fade under pressure. These symptoms can appear in any order and only some may be present. Later symptoms can include seizures and coma. So this slide just shows some of the common symptoms of meningitis and septicemia. As we've already mentioned, fever and vomiting, confusion, delirium, limb, joint, muscle pain, rash, stiff neck, pale or mottled skin, dislike of bright lights, very sleepy, vacant, difficult to waken, cold hands and feet, shivering, severe headache. These symptoms can appear in any order. Not every person who has meningitis will get all of these symptoms, so it's always important to trust our instincts and to get the correct medical help when we feel that something is wrong. Infants are at higher risk of developing bacterial meningitis, and it spreads easily in areas with large gatherings such as creches, schools and college campuses. Other factors that can increase the risk include an anatomical defect or trauma, such as a skull fracture or surgery, which can allow bacteria to enter the nervous system, an infection in the head or neck area, living in or travelling to high-risk areas, having a weak immune system, and working in laboratories or other settings where meningitis pathogens are present. There were 89 cases of bacterial meningitis reported in Ireland in 2018. Vaccination is key to preventing meningitis, and it is important to follow the recommended vaccination schedule. H. influenza is the main cause of bacterial meningitis in children under 5 years of age in countries that do not offer the Hib vaccine. Meningococcal bacteria live at the back of the throat and in the nose. Nasopharyngeal carriage of meningococci is common. About 10% of the population carry meningococci at any given time. However, not all are virulent strains. Most carriers remain well, but they can spread the bacteria to others through coughing, sneezing, sharing personal items such as utensils, cutlery, and toothbrushes, or through kissing and close or prolonged personal contact. Humans are the only natural hosts, and the meningococci organism dies quickly outside of the human host. Meningococcal disease can occur at any age, but the highest rate occurs in children under 5. Group B streptococcus can pass from mother to newborns during delivery. Meningococcal B disease is most common in children under 1, and the next highest risk group are young people aged 15 to 19. The risk of infection is highest in the winter and early spring months. Of those who get meningococcal disease, which is meningitis and septicemia, 1 in 20 will die, and 1 in 10 people who recover will have a major disability, such as deafness, brain damage, or loss of fingers, toes, hands, feet, arms, or legs. Neisseria meningitidis, often referred to as meningococcus, is a gram-negative bacterium that causes meningitis and other forms of meningococcal disease, such as meningococcemia, a life-threatening sepsis. Before the introduction of the meningitis C vaccine in 2000, Group B and C caused most cases of meningococcal disease in Ireland. Since the introduction of the Men-C vaccine, the number of cases of meningococcal disease due to Group C bacteria has fallen dramatically, and most cases are now caused by the Group B bacteria. All children in Ireland are offered the Men-B vaccine at 2 and 4 months, with a booster dose given at 12 months. All babies born on or after the 1st of October 2016 now get the Men-C vaccine at 6 months of age, with a further dose given at 13 months as a combined Hib-Men-C vaccine. This combined vaccine provides extra protection against the meningococcal C infection. The Men ACWY booster vaccine is given in first year of secondary school to protect teenagers up to and including early adulthood from life-threatening meningococcal group A, C, W, and Y infections. Meningococcal disease may present with clinical features that are indistinguishable from those associated with other self-limiting systemic illnesses. Meningitis due to Neisseria meningitidis can begin with flu-like symptoms such as fever, muscle aches, and vomiting before meningitis becomes clinically apparent. Symptoms such as pallor, altered mental state, or limb pain should raise suspicion of meningococcal disease. Rapid onset and progression of symptoms over a period of hours is typical and can help to distinguish it from viral meningitis. A patient presenting with meningitis and a non-blanching petechial or purpuric rash strongly suggests meningococcal disease, although the rash can also be blanching, maculopapular, or even absent. The rash can appear rapidly on any part of the body, including the palms of the hands and the soles of the feet. The rash may go unnoticed unless the acutely unwell patient with a systemic febrile illness is completely undressed so that a thorough search for a hemorrhagic rash can be undertaken. Meningitis due to Streptococcus pneumonia should be suspected in patients with predisposing conditions such as sinusitis, otitis media, mastitis, cerebrospinal fluid leak, cochlear implants, asplenia, HIV, or other immunosuppressive conditions. Meningococcal disease usually presents as meningitis or septicemia, but it can present as a combination of both. Septicemia, with or without meningitis, can be particularly severe and is associated with a considerably greater mortality rate than meningococcal meningitis without bloodstream infection. A presumptive diagnosis of bacterial meningitis is a medical emergency and immediate referral to hospital is required. Antibiotic therapy should not be delayed while initiating referral. Benzyl penicillin should be administered without delay to patients with a systemic febrile illness and a non-blanching petechial or purpuric rash. Ceftriaxone or cefotaxime are suitable alternatives if required. For optimal benefit, benzyl penicillin should be administered intravenously. However, if unable to access the intravenous route, it can be administered intramuscularly. Benzyl penicillin should only be withheld if the individual has a proven history of penicillin anaphylaxis. The doses of benzyl penicillin used for suspected cases of meningococcal disease are: for adults or children 10 years or over, 1,200 milligrams; for children aged 1 to 9 years, 600 milligrams; and for children under the age of 1, 300 milligrams. If benzyl penicillin is unavailable, a third-generation cephalosporin such as ceftriaxone, 80 milligrams per kilogram, up to 2 grams weight, can be administered intramuscularly or intravenously for all ages, or cefotaxime, 50 milligrams per kilogram, up to 2 grams, intramuscularly or intravenously for all ages can be used, and are acceptable for the empirical treatment of suspected meningococcal disease prior to transfer to hospital. It is important to inform the emergency department and clinician at the referral hospital of the patient's expected arrival so that delays in treatment are minimal. Clinical notes accompanying the patient should inform the hospital clinician which antibiotics have been administered and the actual doses given. Antibiotic treatment should not be delayed while initiating or awaiting the results of diagnostic tests. Tests include blood cultures, throat pharyngeal swabs, samples from other sterile sites as clinically appropriate, such as joint, pericardial, pleural effusion, cerebrospinal fluid. Blood should also be taken for full blood count and PCR testing for meningococcal DNA. Serology may occasionally be beneficial, and consultation with a microbiologist should be considered. Lumbar puncture is recommended for all cases with clinical meningitis, but should be deferred until the patient is hemodynamically stable and there are no contraindications such as cerebral edema or raised intracranial pressure. Cerebrospinal fluid obtained from a patient with meningococcal meningitis typically has a high neutrophil count, low glucose, and high protein content. However, low or absent white cells do not exclude meningitis, and initial cerebrospinal fluid tests can be normal in up to 5% of cases. Imaging, such as computed tomography scan, may be recommended before the lumbar puncture to help determine if it is safe to perform the lumbar puncture and if another condition may be contributing to the patient's symptoms, such as a brain hemorrhage or tumour. The long-term outlook of meningitis differ considerably based upon whether it is caused by a virus or a bacterium. However, this distinction may not be clear until the culture results are available, which can take up to 48 to 72 hours. The length of antibiotic treatment depends upon the results of the bacterial cultures. If the cultures are negative and the patient has improved, antibiotics may be discontinued after 48 to 72 hours. If cultures are positive, the length of treatment depends upon the bacteria identified and extent of complications that occur. The treatment course may range from several days to several weeks. Worldwide, bacterial meningitis is among the top 10 causes of infectious-related death. Fatality rates are still very high, and 50% of affected patients suffer long-term sequelae due to severe complications such as hydrocephalus, cerebral edema, cerebrovascular complications, and ventriculitis. Deafness, brain damage, or loss of fingers, toes, hands, feet, arms, or legs are associated complications. Let's have a look at some of the complications. Hydrocephalus in patients with acute bacterial meningitis is associated with worse outcomes. The fatality rate of patients who develop hydrocephalus is about 46% compared to those without, which is 17%. Arterial cerebrovascular complications such as stroke and cerebral hemorrhage occur in approximately 15 to 20% of patients with bacterial meningitis. Vasculitis or vasospasm are the most likely causes of these complications. Septic thrombosis of cerebral veins and sinus occur in about 10% of patients with bacterial meningitis. Epileptic seizures can indicate impending herniation or the presence of an intraparenchymal abscess or encephalitis. Approximately 5% of patients with acute bacterial meningitis experience seizures. Cerebritis and brain abscesses occur in approximately 1 to 5% of patients with bacterial meningitis. On clinical examination, the patient often presents a focal neurological deficit, such as partial paralysis or speech disorder, epileptic seizures, or cephalgia, which is commonly one-sided. Abscesses can be the cause or the consequence of meningitis and are best detected by MRI or MR spectroscopy. Treatment for viral meningitis is mainly supportive. This includes rest, fluids or intravenous fluids if the patient is unable to swallow, and medications to treat fever and headache. Most patients with viral meningitis recover with no long-term complications. Symptoms usually begin to improve within a week, although some will have fatigue, irritability, decreased concentration, muscle weakness and spasm, and difficulty with coordination for several weeks or more. Death is uncommon with viral meningitis. Let's now consider the public health response. The public health response to meningococcal disease includes identification of close contacts, arranging appropriate chemoprophylaxis, and the provision of appropriate information. Chemoprophylaxis is indicated only for those in close contact with a case in the 7 days preceding the onset of illness. It reduces the risk to other susceptible individuals in the network, protecting them from acquiring the meningococcal strain from the carrier and possibly invasive disease. Depending on the serogroup of the index case, vaccination with MenC or MenACWY vaccine may be recommended for close contacts. 3 main antibiotics are used: rifampicin, ciprofloxacin, and ceftriaxone. They are currently the 3 main antibiotics used in Ireland for chemoprophylaxis of meningococcal disease. Each incident requires a careful risk assessment in order to guide the decision regarding which contacts require chemoprophylaxis. Interestingly, it is the carrier who transmitted the organism to the patient in the first instance who is more likely to transfer the meningococcus again, rather than the patient, who is not an efficient transmitter of the meningococcus. Chemoprophylaxis should be given to all identified as close contacts as soon as possible, preferably within 24 hours after notification of the index case. However, it can be given up to 1 month after onset of the illness in the index case. Information is provided by the HPSC. It's recommended information on the prophylaxis indicated for household type contacts. Chemoprophylaxis should be offered irrespective of vaccination status to individuals who have had prolonged close contact with the case in a household type setting during the 7 days before the onset of illness. Examples of such contacts are those living and or sleeping in the same household, including recent visitors who have stayed overnight, pupils in the same dormitory, boy or girlfriend or university student sharing a kitchen in a hall of residence. Babysitters may also be included in this, depending on the level of contact. Chemoprophylaxis should be considered if during the 7 days before the onset of illness, the index case, whether it's adult or child, attended a house party for 4 hours or more with children less than 5 years of age. If chemoprophylaxis is indicated, it should be offered to all attendees, both adults and children, who attended for 4 hours or more. Special consideration should be given to situations in which there is a greater than usual interaction between members of the extended family and an index case, particularly where overcrowded living conditions exist. Other situations with possible close contacts include preschool childcare facilities contacts in certain circumstances. Following risk assessment, chemoprophylaxis should be considered in the following circumstances. Family preschool daycare, which is groups of children which are cared for in a private home, or preschool childcare involving a group staying together in a single room for at least a 4-hour session, or involving a group staying together in a single room for at least a 3-hour session on more than one day. In this situation, chemoprophylaxis may be considered if the setting is similar to a household, example if the children share meals or nap together. Following recommendations regarding chemoprophylaxis among healthcare workers is provided by the HPSC. Chemoprophylaxis is recommended only for healthcare workers whose mouth or nose is directly exposed to large particle droplet secretions from the respiratory tract of a probable or confirmed case of meningococcal disease during the acute illness until the case has completed 24 hours of systemic antibiotics. This type of exposure will only occur among staff who are working close to the face of the case without wearing a mask or other mechanical protection. In practice, this implies a clear perception of facial contact with droplets or secretions and is unlikely to occur unless suctioning during airway management or inserting an airway during intubation or if the patient coughs in the healthcare worker's face. General medical or nursing care of cases is not an indication for prophylaxis. Pathologists and pathology technicians who may be exposed to aerosols during the performance of an autopsy should receive chemoprophylaxis when a face mask has not been worn and when the deceased patient did not receive antibiotics for a minimum of 24 hours prior to death. Exposure of the eyes to respiratory droplets is not considered an indication for prophylaxis. Such exposure may, however, carry a low risk of meningococcal conjunctivitis and subsequent invasive disease. Staff should be counselled about the risk and advised to seek early treatment if conjunctivitis should develop within 10 days of exposure. Outbreaks of meningitis may occur in the general community or in settings such as creches, schools and colleges. The public health action for each of these settings varies and will depend on the identification of epidemiological links between the cases and identification that the same organism is associated with the outbreak cases. The objective of public health management of such outbreaks of invasive meningococcal disease is to interrupt transmission and prevent further cases. Once an outbreak is either suspected or recognised, there is an immediate need to initiate a coordinated response. Following a case or outbreak of meningococcal disease, it is important for public health to disseminate information appropriately as early detection, diagnosis and treatment improves outcomes. Disseminating information to the community often requires the use of mass media, websites, and community meetings and helplines. Vigilance for signs and symptoms among contacts is important, especially in the immediate 1-week high-risk period after the onset of symptoms in a confirmed case. Information disseminated should be sufficient to ensure public awareness of the situation while maintaining patient confidentiality. The family of a confirmed case should be informed that information will be distributed as appropriate. Leaflets or other printed material about meningococcal disease should be widely available and quickly distributed after reporting of a confirmed or clinical case. When a case occurs in a childcare facility, school or college, information disseminated should be sufficient to ensure that parents, guardians, students and staff are made aware of the situation while preserving the confidentiality of the patient. If a suspected case occurs in a childcare or educational facility and public health action is not immediately indicated, for example in a case where diagnosis other than meningococcal disease is likely, it is still advisable to discuss the situation with the manager or head at an early stage, who will then be in a better position to respond to concerns. The need to inform other HSE colleagues, GPs and GP out-of-hours services about the case and what public health actions have been taken or are required must also be considered. Vaccination provides the best chance of protection against meningococcal disease. Opportunistic discussion in practice with patients helps reinforce the importance of vaccination programs and adherence to the recommended schedules. Providing education to pregnant women and their partners about the importance of childhood immunisation programmes can help increase knowledge, vaccine uptake, and the timeliness of receipt of childhood vaccinations. Discussion involves debunking myths and addressing parental concerns about vaccine safety. Clinicians must continue to address the gaps in patient knowledge through detailed educational efforts and effective communication techniques. It is important that practice nurses and doctors are up to date with research and immunisation guidelines and are able to communicate effectively the benefits and importance of vaccination. Effective communication techniques, providing evidence-based information and best practice advice, can address misconceptions and gaps in patients' knowledge, leading to informed choices, better patient understanding, and improved outcomes. Following is a list of references that were used in the production of this presentation. Thank you for watching and listening to this presentation on meningitis, which is part of an online education series for general practice nurses produced by the Irish Practice Nurses Association. My name is Teresa Lowry-Lenin. I'm a member of the Carlow branch of the IPNA. Thank you.